Welcome to Unit 20, Meeting the Resident's Need, Maintaining and Restoring Mobility. In this unit, we will describe what is meant by restorative care. We'll identify the reasons for restorative care, the state and federal regulations, fulfilling the resident's Bill of Rights, and belief in the resident's dignity and worth. Restorative care. Restorative or rehabilitative care refers to nursing interventions that promote the resident's ability to adapt and adjust to living as independently and safely as possible. Another description is helping the resident attain and maintain the highest level of functioning possible. This is extremely important. Over 87 states, the federal and state regulations, that we prevent deterioration or functional decline conditions in our residents. We need to be able to keep them in the highest mobility as possible. Remember, if we don't use it, we lose it. Reasons for restorative care. It is a state and federal regulation. It also is expected to fulfill the resident's Bill of Rights and to demonstrate a belief in the dignity and the worth of each person or resident. Restorative care overview. It relates to all aspects of the resident's care. It stresses preventing further disability. It strengthens what the resident can do rather than focusing on what he or she is unable to do. We always need to remember that each resident is a unique individual, and we need to base their care off of their personalities, their beliefs, their practices, and their habits. Also, rehabilitation services are often provided more intensely for a shorter period of time. This would be for like our skilled residents that are only coming in for strengthening to get them back on their feet. They're not well enough to go home, but they're not sick enough to be in the hospital. And so they come into the facilities as a skilled resident. Let's identify some examples of restorative nursing program components. These are not limited to just the ones that we're going to talk about. There are some other ones. The first one is range of motion. The abbreviation is AROM. You must know that abbreviation. Mobility includes the bed or chair mobility, transfer activities, ambulation, use of splints or braces and prosthetic care, eating or swallowing, bathing, dressing and grooming, toileting and elimination control, and communication. These are all part of restorative. And you will be doing restorative care all the time when you're caring for your resident. Anytime you do any kind of mobility, that's restorative. That's strengthening the resident. That's getting them to use their muscles and their joints. And it's extremely important that we keep them doing this because, like we said before, if you don't move it, you lose it. So activities of daily living, basic tasks of everyday life, like I said, like eating, toileting, bathing, dressing, moving, and walking, that is all restorative. you're constantly moving the resident, exercising them, and that is all included in meeting their mobility. We're going to talk about some specific terms that are used to describe assistance giving to the resident. Understanding them will help the CNA accurately follow the care plan and communicate with other members of the team. It's very important that you learn these terms as well as all medical terms that we have provided in the content of this online program. The first one we'll talk about is self-care deficit. This is when they are unable to perform any of the ADLs without assistance. So they pretty much need total assistance. Task segmentation means breaking up an activity into small steps or subtasks so that the resident can accomplish them. An example of this, if you have a resident that has any kind of respiratory problems, any activity, physical exercise is going to cause them to have increased respiration. So they can get really short of breath with any kind of movement and exercise. So this is why it's important that we use task segmentation. And that's to kind of break up how we do things with them. Allow them to take breaks in between maybe getting up and dressing, and then maybe in between dressing and brushing their teeth and combing their hair. Allow for their respiratory system to catch up with them. Once you notice that the resident is respirations have increased, you need to slow them back down. Because you don't want them to get real short out of breath and then get into a crisis. So if they wear oxygen, make sure their oxygen is on and that it's in their nose, that the machine is turned on and the tubing is all connected. And make sure that there's water in the humidifier. So this would be a good example of task segmentation, is allowing a resident with respiratory problems not to get too short out of breath. So we're going to give them things to do in small segments. Additional assistance such as verbal or physical cues aid the resident in accomplishing their small steps and therefore the whole activity. And, verbal cues are just that, verbal cues. Okay, now we're going to get dressed. Now we're going to put your pants on. Because remember, you should always tell the resident what you're doing, no matter if they can understand you or not. You'll learn that hearing is the last sense to go. So always explain to your resident what you are doing. Setup, that's a pretty easy one. That's preparing the resident to perform the activity. Good example of this would be to allow the resident to brush their teeth. You get their toothbrush out, you put toothpaste on it, you get them a cup of water to rinse their mouth out, and maybe a towel to wipe their mouth, and you have that all laid out at the sink. So all you need to do is to push the resident up to the sink and then allow them to perform the activity. Positioning, this is preparing the resident to perform the activity by placement of the body or extremities. So depending upon what you're going to do with that resident, you're going to want to position their body and their extremities so that they are able to perform this activity. Oversight, that means that you're going to stay near the resident and watch the activity. Be prepared to cue or otherwise assist the resident as needed. This is also called guarding. You're just sitting there observing and waiting for the resident to see if they're going to need any assistance. Cue means showing or prompting the resident to perform the activity. Cueing may be verbal or nonverbal, physical. So, if they were, say, they had their toothbrush in their hand And they were just kind of looking at it and didn't know exactly what to do with it. So you might pretend like you have a toothbrush in your hand and bring it up to your mouth and kind of mimic brushing your teeth. That's cueing. Guidance maneuver is touching or moving the resident's limbs through the steps of the desired activity. It's a hand over hand technique. It's a good example. Coaching, you're going to encourage the resident to perform the activity, providing praise and even with small success. Now, when I say praise, that doesn't mean that you're going to say, oh, you're such a big boy or such a big girl. That's not the kind of praise that we need to be doing. We need to remember that these are adults and that they are not children. So you might just say, you did that very well. So, watch the way you praise them and the words that you use. We have to be very, very careful not to treat them like children. Coaching, we just did that one. So let's go to pacing. That, again, is allowing time for a task to be completed by the resident or for the resident without making the resident feel rushed. So that means just allow them the time to get it done. Remember, they're not as fast as we are. Their bodies are slower. The way they do things is much slower. And really, they have all the time that they need. I mean, time is really all they have. So allow them to do this on their own pace. It's extremely important that we do that. So you need to understand all of the above restorative care terminology that we just went over. There are lots of state questions on restoring mobility. So it's very important that you read this unit completely in your book and then ask any questions when we come to clinicals. Now let's talk about the CNA's responsibility for restorative care. The CNA needs to be skilled, competent, and consistent in providing care, following and contributing to the resident's care plan, keep accurate records, demonstrating an attitude that is regaining and maintaining and improving the function as desirable and possible for the resident, and demonstrating an attitude of respect for the resident. This is very important. Remember, we must respect our residents, and we need to remember that helping them to maintain their mobility really does give them self-worth. No matter what they can do for themselves, by just allowing them to do it, that gives them a sense of accomplishment and again gives them self-worth. Now we're going to talk about some complications of inactivity. And we've kind of talked about this throughout all of our units. But physical changes, inactivity, and immobility have serious physical consequences. If the resident stays in any position too long, whether sitting or lying, an adverse body changes are likely. Restorative care and adequate activity support physical and emotional well-being. Inactivity leads to further decline. Good care does not mean doing everything for the resident, but empowering the resident to do what is possible for them. Please remember this. Again, we have to stress independence, allowing them to do as much as possible for themselves. Now, I'll tell you, there are some residents that'll talk you into doing a lot for them. So you need to counteract that and get them to do it for themselves by distraction, by talking to them about some of their life accomplishments. And even say, well, if you do this, I'll do this amount for you. But push them, push them, push them again, to do as much as possible for themselves. Now let's talk about some consequences of inactivity with the musculoskeletal system. The muscles weaken is called atrophy. Their joints tighten, producing contractures. The bones lose calcium and other materials that keep them hard and strong if they do not bear weight, resulting in osteoporosis and increases the frequencies of fractures. And remember that, anytime we have a resident that falls or has fractures, this takes a lot of recuperation. I mean, it takes them a lot of time to heal from these. And because of that, if they lose some of these things with their musculoskeletal system, they're going to lose their mobility and they're going to get weak, causing the contractures. So we need to be very careful and, again, promote independence and mobility. Now some consequences of inactivity with the skin, the integrity system, particularly the skin. Pressure from not changing position deprives the tissue of O2 and nutrients, and that causes decubitus ulcers. I will tell you that on the state test, they are not going to say bed sores. They're going to say decubitus ulcer. So please know that that is a bed sore. Know that the first sign of a decubitus ulcer or bed sore is redness that doesn't go away within 30 minutes. So if you have a resident that you turned and you notice a big red spot on their hip, and say you come back 30 minutes or 45 minutes later and that redness is still there, we now have stage 1 of a decubitus ulcer. This is extremely serious. State will come in when they do their survey and they will go through our charts and our care plan with a fine-tooth comb. And if they figure out that a resident had a pressure ulcer because of us, we're going to get a deficiency. And so anytime we see things that start, we should immediately put interventions in place to keep it from getting any worse. So with this red hip, it didn't go away within 45, 30 minutes. It was still there. So what are we going to do about it? Well, we're going to put this resident on Q2 turns. So we're going to alternate them off of their side, and we're going to move them from the left side to the right side to their buttocks every 2 hours. Or another example would be if they're sitting in the wheelchair, have them push up with their hands and reposition their hips so that we can get some of that stress off of that hip. Also, some other things are we can use, we can put pillows in place, we can put foam pads in place, we can put a better air, like an air mattress on their bed that distributes the pressure. So there's a lot of things that we can do, and of course all these things will be in the care plan. Now, the urinary system, with this, minerals are lost from bones, and they can cause some problems in the kidney and bladder with stones. And again, that's because their whole systems are slowing down. It's the inactivity. It's associated with difficulty urinating and incontinence. We need to, make sure that we toilet our residents every 2 hours. And again, we need to encourage fluids, encourage fluids, encourage fluids. The gastrointestinal system, inactivity is associated with slower bowel function and constipation. We're up moving all during the day. We're up walking, moving, running, sitting, we're constantly moving. And so our gastrointestinal system is moving too. As we age, though, however, we know most residents, their activity level is pretty low. And so because of that, their stomach doesn't have good mobility and therefore causes constipation. And that could be a serious problem. Anytime you have a resident that's constipated, please inform the nurse immediately so that we can start giving them some kind of a bowel prep to help them to relieve their constipation. Also, you need to make sure that when they are eating, that they are in the upright position so that they don't aspirate on their food. When they're sitting straight up, the chances of that decline. With the respiratory system, their breathing is more shallow. Therefore, fluids and secretions tend to accumulate, giving them pneumonia, which is an infection of the lung tissue. Again, think about it. When you're in a resting position, what's your heart rate like? It's pretty darn low. And your breathing is very slow and very shallow. Now, if you get up and start running, moving real quick, your heart rate goes up, your respirations go up, your breathing gets deeper, your lungs expand out more, and so the risk of pneumonia is down. So, whatever activity, again, we can do for these residents that increase their respirations and make them breathe deeper and expand those lung fields, then we can reduce pneumonia. And remember, there's 3 things we need to be careful of: falls, pneumonia, and urinary tract infections. Now let's talk about the cardiovascular system. With immobility, the heart muscles adapt to the increased demand and is impaired by inactivity. So let's kind of restate that. The ability of the heart muscles to adapt to the increased demand is impaired by their inactivity. So their heart is not pumping effectively. Their circulation is slowed down. The lack of muscle movement and pressure from the lack of position changes contributes to the formation of blood clots. And that's a big concern with elderly people. Because that heart's not pumping, it's not circulating completely throughout their whole body. It gets stasis, it just stays in one place. We have a chance of blood clots forming. This could be a serious problem for our residents. So again, move them, move them, move them. Complications of inactivity or immobility forms pressure ulcers. Other names that are used is skin breakdown, decubitus ulcers, or bed sores. Remember that we must prevent these from happening, and that's why it's very important that we encourage our residents to move and to reposition frequently. Now we're going to talk about some risk factors for pressure ulcers. This happens anytime the skin is disrupted or it gets diminished O2 or nutrients to the skin and the underlying tissue. This can cause some skin issues like pressure ulcers. Anytime a resident has a limited ability to change position in bed or chair, they could get a bed sore. So it's very important to remind them to reposition themselves in the chair or the bed. If a person is bedbound, which means that person's not able to get out of bed by themselves, we probably use a Hoyer lift for them. So therefore, they're not even able to reposition themselves in bed. This is when it's extremely important that we change their position every 2 hours and PRN as needed. Sometimes there's some damage to the skin and the underlying tissue during repositioning. by what's called friction and shear. The definition of friction is damage to the skin that occurs when the skin rubs up against another surface. For example, that would be like when you're repositioning a resident in bed and you slide them up on the sheets, that can cause friction. The definition of shearing is stretching the skin in one direction while the underlying bone moves in the opposite direction. Again, this can happen with repositioning. If you have a resident that's incontinent of bowel or bladder, or has other skin moistures such as between the folds of their skin, a lot of times moisture will collect there. But just the incontinent of bowel and bladder, when this comes in contact with the skin, the feces or the urine, it can cause some problems with their skin. That's why it's extremely important that when you do clean a resident up after they've been incontinent, to make sure that you clean the entire buttocks. Anywhere that the brief can come in contact with the skin, we need to wash that area very well and thoroughly. Because remember, when they are incontinent in their brief or the attends, the purpose of those products is to absorb the urine into the product. And so that what happens there is it gets distributed throughout the whole brief, so it can touch all the surfaces of the skin wherever the brief or the depends is. So again, clean that area very well, and as soon as you see some changes there, report it to the nurse immediately. We have a lot of products that we can use to help with any kind of skin breakdown, even to prevent skin breakdown in the peri area. There is a barrier cream that we can use that repels the urine and the feces away from the skin. And then there's some other products that we can use once they start to break down or start to have like a rash or redness area. That's not usually due to pressure. That's due to the incontinence of the feces and the urine. Now, we should always check in the folds of their skin, especially for residents that are obese and they have a lot of folds, or with residents that have large breasts that are now drooping down. We need to clean underneath those breasts and in those folds really well, and then we need to dry them very well. Pat dry them, don't rub them, again, because that could cause some skin issues. So pat dry those areas. Open up those folds, clean real well with soap and water, and then again pat those areas. Never apply powder in those areas. That's a great product to help to cause a yeast infection, so we don't want to use powder. Again, just washing them with soap and water and pat dry them is sufficient. Also, there are some medical conditions that interfere with good blood circulation or supplies, particularly to the extremities. And with this, when they don't have good circulation, again, that oxygen and that nutrition is not getting to that tissue like it should be. Therefore, we can have some sores developed and some red areas developed from both not getting the O2 and nutrition and also from pressure. It says also in your book, limited movement with restraints. We don't really use restraints in the long-term care facility. It's been pretty much abused in the past, and so OBRA and the state and federal government has really come down hard on facilities And when they have to use restraints, there's a big, huge protocol that follows it. So anytime that you do use those restraints, make sure you know the reason why we're using them and know the frequency of how much you're supposed to be checking them and repositioning them. But the areas where the restraints are applied, for example, there are wrist restraints. With the wrist restraints, you're going to want to check that wrist area because we want to make sure that the restraint's not on too tight, that they're still getting good circulation. But we also are going to want to, check that skin because they might be pulling on them and, wiggling their arm a lot, and it could cause some skin irritation there. So let's talk about some more signs of tissue breakdown or pressure ulcer formation. Any of that, of course, should be promptly reported to the nurse. Some areas that you need to be checking would be check the bony providence areas where the bone is very close to the skin. Some examples would be the elbow, the knee, the ankle, the heel, the spine, the sacrum, the coccyx, and the hips. Check the skin folds. Again, make sure that there's no moisture in there. If it is, dry it off. Observe for changes in skin color such as redness or darkness, particularly when it does not disappear within 30 minutes after the pressure is removed. Other early warning signs are warmth and tenderness at the site. The resident reporting any kind of a burning sensation. We need to observe that area and report it as quickly as possible. Check for broken skin or formations of blister-like lesions. This is a sign of increased damage. Damage below the skin surface occurs before the skin actually breaks down. Anytime you see blisters, of course, report it to the nurse immediately, but never pop the blisters. The reason why is that this is a sterile environment. Remember, our skin is our shield. It's our barrier. It protects us from microorganisms entering our body. So as long as our skin is intact and we have no open areas, then we don't really have to worry about microorganisms penetrating through open areas of our skin. So not only, too, that we need to watch the resident skin, we need to watch our own skin. Because remember, we have to take care of ourselves, too. So, with washing your hands as frequently as you will be when you enter into the healthcare profession, your hands are going to get dry and crack open. And so with saying that, we need to, protect our own skin. Make sure you use good lotion, dry your hands real well. If you do have an open area, you should cover it and wear gloves when you're caring for a resident. More advanced damage is shown when a crater forms after the deeper tissue is destroyed. Damage may extend into the muscles and to bones and joints. So this can get really, really serious. And that's why it's, again, so important that you observe the resident's skin as much as possible. Anytime you have a chance to visually look at their skin, do so, and again, report anything that's changed in the resident's skin, any open areas, bruises, rashes, scratches, anything to a nurse right away, because this needs to get documented. And not only does it need to get documented, we need to get interventions in place, remember, to keep them from getting any worse. That is extremely important. And always remember that prevention and management of pressure ulcers, a little saying, an ounce of prevention is worth a pound of cure, is true in the management of pressure ulcers. It is much more time consuming and costly to heal a pressure ulcer than it is to prevent one. So again, let me just emphasize that prevention is extremely important. Reporting any changes in their skin immediately to the nurse is very important, so that we can get these documented and again get interventions in place to keep it from getting any worse. Some key points, including preventing functional decline and addressing potential causes for injuries, is encourage the residents' mobility in whatever they do. Encourage the residents' mobility in bed or chairs. The resident changes positions using devices such as a trapeze or an assistant rail as needed. A trapeze is just like a triangle. It's a bar that hangs over the resident's bed. So this helps them to reach up, grab the bar, and pull up and reposition themselves. Again, though, they have to have good upper body strength to be able to do that. And with residents that already have problems with immobility, the trapeze might not be a good idea because, again, they don't have the upper body strength to pull themselves up and reposition themselves. The resident changes positions in the chair with push-up and with shifting weight from side to side. The resident has a wheelchair that is user-friendly, enabling him or her to be able to move independently. So when they're sitting in the wheelchair, again, just have them put their hands on the armrest and then push up to put their distribute their hip from to distribute their weight from one side to the other side, alternating them with also sitting on their buttocks. We need to prevent shear or friction injuries through proper positioning, prevent sliding. We need to use proper lifting. Help the resident use assistive devices that enable good body alignment and position. Support different areas of their bodies with splints or orthotics or braces. These devices are used to help the resident maintain alignment and position in order to better be able to function, use those extremities or just repositioning themselves. So we do use these different products to help them keep good body alignment, in other words. Assist the resident to reposition at times and intervals that keep healthy skin over the bony providence areas. Avoid massaging tissue directly over the bony providence areas. You don't want to do that. Use pressure reducing surfaces and padding devices in addition to helping the resident change position. With using these different devices, some examples would be a gel-filled pad, say in their chair, foam heel protectors, elbow protectors, therapeutic beds like air beds or gel beds, cushion side rail pads so that they don't bump themselves, a wedge that goes in between their legs, and pillows. We can use pillows too. Provide routine skin care in the folds and the creases. Again, we've talked about that. Provide good skin care promptly after the resident has been incontinent. That is very important. Usually we do what's called a check and change for people that are incontinent. And what that means is every 2 hours we check them to see if they need to be changed. And if so, we do so. Now, if you know a resident at an hour after you change them is completely saturated in urine, I mean, don't wait till the 2 hours is up. Change them immediately because, again, that skin, that urine is coming into contact with the skin. The longer it stays there, the better chances of having some skin issues like a decubitus ulcer start. Keep their bedding dry and free from wrinkles. Encourage the resident to participate in a toilet assistant program. For example, if you know a resident is incontinent of bowel and bladder, why can't you still toilet them every 2 hours? Well, you can. Just because they're incontinent doesn't mean they have to be incontinent in their brief or attendance. If you know Mr. Smith, every morning after breakfast, you can count on it, he's going to have a bowel movement. So why don't, right after breakfast, you take Mr. Smith into his room and you set him on the toilet. Chances are he's probably going to have a bowel movement. That's what you need to emphasize with your residents, that they don't just have to be incontinent in their briefs, that we can still toilet them. You know, they lose the ability to sometimes even sense that they have to go, but sitting them on the toilet, something just, they automatically go. So let's encourage toileting them as much as possible for residents that are incontinent. Encourage the resident to have a good nutrition and adequate fluid intake. This is very important too. It helps with keeping our integrity system, which is our skin, in good condition. Now let's identify the difference between active range of motion, which is AROM, and passive range of motion, which is PROM. Active range of motion occurs when the resident can move his or her own joints, while the CNA assists the residents to move joints, but the resident performs the activity. This is termed active assistant range of motion. Now, passive range of motion, which is PROM, occurs when the nursing staff or therapist moves the resident's joints, providing exercise. For an example, passive range of motion would be used on a resident who has been paralyzed and their extremities are paralyzed. And so when they're paralyzed, they can't move them at all. So that's passive because we have to do it. Active, they can do it. Now, we need to talk about some safety considerations that the CNA needs to keep in mind when assisting the resident with range of motion. When exercising a joint, you should never push it past the point of discomfort or to the point of a firm stretch. When you're exercising the resident, the resident's going to feel a little pain. But when the pain is discomfort, when it really hurts, we need to stop. So never push the joint past when the resident says it hurts. Never force a joint to move. If you have a resident that has a contracture and you force that joint to move, you can actually break it. Check with the nurse when the resident expresses pain during range of motion. Also, if there is a wound or skin tear on the joint to be exercised. And if the resident is combative when you try to attempt to do a range of motion on the resident. So report all this to the nurse as quick as possible. Now we're going to talk about some range of motion terminology. Adduction is moving a body part away from the midline of the body. Adduction is moving a body towards the midline of the body. So this is how I remember it. Adduction, moving away from your body. I think of somebody taking something away. So, like an abduction of a child, somebody took that child away. So I think of that as remembering that I'm going away from my body. Then adduction, I think of adding numbers together, bringing it together. So that reminds me of bringing towards the body. Flexion is bending a body part. So if you take your arm and you hold it out in the air, and you take your hand at your elbow, you bend, that is flexion. You bend, the bending of a body part. Extension is straightening that body part out. So when my arm was straight out, that's extension. When I flex it at my elbow because I'm showing off my muscles, that is flexion. Congratulations, you have completed Unit 20, meeting the resident's need in maintaining and restoring mobility.